let's wait for more participants.
Participants. Oh yeah, there's only 6 of them. A very good morning, everyone. Thank you for joining us today. I'm Vani, and I'll be serving as your moderator for this session. To begin with, there'll be a short commercial video sponsored by Beckman Coulter for your attention. Let us watch the video now.
At Beckman Coulter, we are committed to advancing healthcare for every person. We offer a unique combination of people, processes, and solutions designed to help clinical laboratories and healthcare networks elevate their performance and advance patient care. Accelerate care with a menu that matters. Provide the right patient insights at the right time, addressing critical health risks. Automation solutions designed to fit your laboratory. Deliver accurate results, reduce errors, and experience more efficient workflows. Save time, increase productivity, and inform decision-making with innovative lab IT solutions. And achieve operational excellence for your laboratory with a Beckman Coulter Performance Partnership.
Well, that's the end of the commercial video. Next, we'll move on the lectures. Just a little housekeeping before we get started. There will be 2 interesting lectures in this session, and each of the session will have the duration of 45 minutes. If you have any questions, please type them into the Q&A box, and I'll bring them up at the end of the presentation. Now, allow me to introduce our first speaker, Dr. Ho Ziwei. Dr. Ho Ziwei is currently the Scientific Marketing, Marcom, and Digital Marketing Leader at Beckman Coulter Diagnostics. She has received her doctorate degree in Physiology from National University of Singapore. For the past 4 years with Beckman Coulter, she has been involved in many projects, trainings, clinical studies, and evaluations in the field of IA and hematology, as well as delivered numerous talks across different disease spectrums. Without further ado, I would like to welcome Dr. Ho Ziwei to deliver her talk on early detection and management of sepsis with novel biomarkers. Over to you, Dr. Ziwei.
Thank you, Vani, for the very kind introduction. I'm trying to share my screen.
Yeah.
Can you see my screen?
Yes, doctor, I can see.
Okay, great. So good morning, everyone. Happy to have the opportunity here to discuss early detection and management of sepsis with novel biomarkers. My name is Sui, and I'm the Scientific Marketing, Digital Marketing, and Marcom Leader for Beckman Coulter at High Growth Markets. So the agenda of my talk today, I will give an overview on sepsis. What exactly is sepsis? It's actually a very, very complex condition and can present in many, many different ways. I'll also talk a little bit about what are the current and previous sepsis detection and management guidelines, after which I will highlight on some of the key biomarkers for sepsis detection and management. I think I've tried to focus on novel biomarkers, and in this case, I will spend some time talking about IL-6 and monocyte distribution width, or MDW, for sepsis detection and management, but I'll also talk about procalcitonin, which, as you all know, is not really novel, but I would say that in our Asia-Pacific region, the use of PCT is still not very widespread due to a variety of reasons, which we can also discuss in the Q&A section, and followed by some concluding remarks. So what exactly is sepsis? Sepsis is a systemic inflammatory response to infection. However, when this response is dysregulated, it can actually result in a variety of life-threatening conditions, including organ dysfunction. And we often see that sepsis can progress to septic shock in very, very critical situations. And this is where circulatory and cellular metabolism abnormalities are profound enough to really increase mortality. What are the causes of sepsis? It's really due to any infection, and it can be caused from infection in the lungs, urinary tract, abdomen, or other parts of the body. Sorry, let me go back. And many types of microbes, including bacteria, viruses, and fungi, can also cause sepsis, but really bacteria are the most common, and that's where procalcitonin can play a role as well. So what about in our region, right? So in Asia Pacific, it's home to 4.6 billion people, which is really 60% of the world's population. So it's a very populous region, I would say. And the interesting thing is that sepsis incidence is very varied, right? From the more developed regions, it can range from 120 per 100,000 people, into the less developed regions, it can be from up to 1,600 per 100,000 people. And mortality rates in such less developed regions could reach up to 35%, which is much higher than in Western and other high-income countries. Generally, I would say that in developed or high-income regions, incidence of sepsis is actually fairly low, at less than 8%. So overall, I would say that due to the diversity of the Asia-Pacific region, we do have a high burden of sepsis proportional to our population, as well as the highest number of patients affected by sepsis globally. And in this map, we can see that, in our region, we do have the blue areas, which reflect the 1,600 to 2,500 incidences of sepsis per 100,000 people. So with sepsis being such a critical condition and a global healthcare burden, especially for our region, it's no surprise that it is one of the conditions that has been discussed in the context of critical illness. So what exactly is critical illness or critical care medicine? So critical care medicine generally deals with patients who have a reasonable chance of discovery. And here, such a list of conditions, we should try to distinguish it from other disciplines dealing with serious irreversible medical conditions such as advanced cancer. And because there is a reasonable chance of recovery, it is important that these conditions should be amenable to protocolization. The advantages of protocolization are that you can standardize and reduce unnecessary variability in care. Of course, such a condition, I put a star here, is sepsis. Such streamlining of care, improved communication can also contain costs because you do not order unnecessary tests for the patients, and overall it helps to decrease errors and improve safety. So why do I talk about protocolization and management of critical illness? Because later on, when I talk about some of the management and treatment guidelines for sepsis, you'll see that there are very standardized ways of managing and ordering tests to manage these patients. And then after that, I'll come into maybe discuss a little bit more on where these novel biomarkers can fit in such protocolization as well. So speaking of biomarkers, right, actually sepsis is a very hot topic for biomarker research. And I would say in the last 10, 20 years, there has been a lot of research on biomarkers across different classes. And this is because sepsis is a condition that arises from dysregulation of an immune reaction to an infection. So if you think about it, any marker involved in the immune process or dysregulation could potentially be a biomarker. And it's really fascinating how there are so many categories here, right? From soluble receptors to DAMPs or chemokine ligands, all the way to miRNA and non-coding RNAs. And these are all potential biomarkers that have been reviewed recently as potential markers that could be used for detection of sepsis. Some of the more common ones, more common novel markers that we've heard about in the last few years would be presepsin, SUPAR. You can see that the area under the curve for these markers are actually fairly high. Chemokine ligands like MCP1 has been around for a long time, has been implicated in immune signaling, huge inflammatory responses. And I think what I find really interesting are also the mRNAs and non-coding RNAs, right? The fact that these are also released in septic or even septic shock cases. However, I want to put maybe not a note of caution, but I want to maybe highlight to everyone that although there are many biomarkers currently being highlighted as potential aids in the diagnosis of sepsis, the reality is that they are not always accessible to the healthcare professional. A lot of these are research-based, or maybe they are ELISA-based type of kits that could work well for a small cohort of patients. But when you are dealing with large volume of samples coming in, really you want something that can be automated, has a short turnaround time, as everyone knows, and of course provide reliable results. So, for example, I think for quite a number of these novel biomarkers, we're not quite there yet in terms of implementation of their usage in the protocolization of sepsis in order to standardize and improve patient care overall. So I also want to talk a little bit about sepsis diagnostics and treatment guidelines. So the most recent sepsis guidelines is Sepsis 3, and this was developed in 2016. But prior to Sepsis 3, Sepsis 2 guidelines was used for a very long time. I believe it was developed in the 90s. And so all the way up to Sepsis 3 guidelines were developed, Sepsis 2 guidelines were very, very prevalent. As a result, I think even in Asia Pacific today, there are some pockets of the region where there are still Sepsis 2 is still being used in in clinical practice. So maybe I can discuss a little bit more about this as we go along as well. So what's the difference between Sepsis 2 and Sepsis 3 guidelines? So in Sepsis 2, suspected infection and inflammation is already classified as sepsis. And this goes according to the systemic inflammatory response syndrome, where an elevated temperature or heart rate, respiratory rate, or abnormal blood count is at least two of these parameters could result in a patient diagnosis as sepsis. However, what was considered as sepsis previously is now considered as infection, maybe with an ICU stay. And in fact, there's a new scoring system that has come about as a result of implementation of Sepsis 3 guidelines since 2016, which is the Systemic Organ Failure Assessment Score, or SOFA score. This is actually a very comprehensive scoring system that looks at organ function across the different types of organs. But in the emergency department, physicians frequently use what we know as a quick SOFA score or Q-SOFA score. So to be classified as suspected infection and inflammation, Q-SOFA score has to be more than 1. And what are 3 parameters that are being judged for or utilized as part of the Q-SOFA criteria? We look at the mental status of the patient, systolic blood pressure, any drop in systolic blood pressure, or increase in respiratory rate. So what is now classified as sepsis in Sepsis 3 was actually previously classified as severe sepsis. And now, according to guidelines today, if patient experiences organ dysfunction as a result of this systemic organ failure assessment score change, then he is diagnosed as septic. Whereas this was previously severe sepsis. And upon the diagnosis of sepsis, which is considered as time 0, the treatment bundle as per the surviving sepsis guidelines is then initiated, which could include lactate level measurement, broad spectrum administration of antibiotics, blood culture, and this all happens at the 3-hour point. And at 6 hours, patient could have repeat lactate measurements done to see if initial measurements were elevated. After that, the patient may progress, if he doesn't respond well to treatment, he may progress into septic shock. And here, the definitions are consistent across the old and the new guidelines. And you can see that with that also there is a certain guidelines with regards to the treatment bundles that should be initiated at this point in time. So I think with the implementation of Sepsis 3 guidelines in 2016, what we saw then was a much more clarity in definition of sepsis, right? Sepsis is not just any infection. It is only when there's evidence of organ dysfunction due to infection as per SOFA scoring, then patient can be classified as septic. But what also happens is that some of the feedback that we've gotten throughout the region is that some physicians or some healthcare providers still go to the Sepsis 2 guidelines because they say that when you wait till organ dysfunction, when there's evidence of organ dysfunction, sometimes the patient deteriorates really, really quickly. And if you wait to that point to administer treatment, it may be too late. So I think in reality, we have also learned that there are physicians who use a mix of Sepsis 2 and Sepsis 3 guidelines in their daily practice. But I think overall, it is really important to have a biomarker that can detect sepsis early so that they're given the right antibiotics at the right time. Of course, we do not want to prophylactically give antibiotics, as you all know, with the rise in the incidence of antimicrobial resistance. So it's always the key. The key is always about detecting sepsis early enough so that the right antibiotics can be given to the right patient. So speaking of detecting sepsis, as you know, sepsis is a result of dysregulated immune reaction to any infection, thus resulting in overall organ dysfunction as defined by a high Q-SOFA score. So how do we diagnose sepsis in the laboratory? And I won't really go into details because I'm sure everybody's very familiar with it. Usually blood, urine, or CSF or bronchial fluids as specimens are taken, and these are cultured, and usually takes 24 to 48 hours. But as you know, sometimes cultures don't always work. So it really depends on, so this is considered still the gold standard, blood cultures, but the success rate is not always very high, and the turnaround time is long. So what are the routine laboratory tests for sepsis? We have CBC, white blood cell count, CRP, lactate. There's also been pro-inflammatory cytokines that can be evaluated as part of this process of diagnosis of sepsis. And these pro-inflammatory cytokines include TNF-alpha, IL-1 beta, or IL-6. Procalcitonin, of course, is another key biomarker. So you can see here that this is a very interesting series of time kinetics at which the different cytokines and biomarkers are rising. So you can see that IL-6 rises the earliest, followed by PCT and CRP. So IL-6 actually has been considered as a very early biomarker that rises in response to a dysregulated immune response, which could be due to an infection. And in fact, as some of you may know, IL-6 was also very widely used during the recent COVID pandemic as an indicator that the patient is experiencing this cytokine storm or this huge inflammatory response. So this is another example of the septic cascade and the biomarkers and symptoms that involve. So like I mentioned earlier, sepsis is a result of any infection, a dysregulated immune response to any infection. This infection can take place in a variety of locations in the body, from the skin to the lungs to the GI tract and the urinary tract. And you have this initial innate immune response, which is usually driven by neutrophils, monocytes, and the tests in bold are the ones that are offered by Beckman Coulter. So some of the markers that I'll talk about are highlighted here very early on in the septic cascade at the infection phase. And this is monocyte distribution width, which measures the change in monocyte volume, shape, and morphology, as well as the inflammatory cytokine cascades that are triggered as a result of this innate immune response to an infection. And I'll also talk about IL-6 later on in this presentation. So during the inflammatory response, then there are different things going on across different organ functions, and some of the typical biomarkers that you can see that are being elevated would be C-reactive protein. And at this point, monocyte distribution width is also elevated. And with bacterial infections, if they progress to a more critical situation, procalcitonin is also elevated as a result of the release of endotoxins and exotoxins. As patient progresses into sepsis, he may experience delirium. You can see tachycardia, tachypnea. You may see hypertension, microclotting, resulting in a drop in platelets. There could be tissue hypoxia resulting in release of lactate, which is why lactate is part of the treatment bundle, or lactate measurement is part of that treatment bundle at 3 hours, as per the surviving sepsis guidelines for treatment of sepsis. And when patient eventually progresses into severe sepsis and septic shock, this is where a variety of these biomarkers, very standard panels, are being released from the different organs as a result of this progression into severe organ failure. So where do we stand in the management of the septic patient? So this shows an overall view of the Beckman Coulter IVD portfolio for the septic patient. As you can see, as the patient progresses from being just generally unwell, where he can get a CBC drawn just to measure his condition at that point in time, as well as maybe a basic metabolic panel, right? With the suspicion of sepsis, usually lactate, CRP can be ordered. I think what we have seen with the COVID pandemic is that a number of healthcare providers have also started to order IL-6 because COVID patients do deteriorate really, really quickly, and IL-6 is also another marker that not only has been implicated in sepsis, but also as an indication that the patient's undergoing this huge inflammatory response that is known as the cytokine storm. So these assays are actually available on our clinical chemistry and immunoassay platform. For example, IL-6, we have it available on the immunoassay platform as well. And in terms of when patient progresses into symptomatic sepsis and septic shock, then again, a wider variety of tests are also ordered. So across the different spectrum of panels that can be ordered to manage and detect sepsis early on, from clinical chemistry, immunoassay, hematology would be the CBC or monocyte distribution width. We do also offer our urinalysis and microbiology solutions to help manage the patient who comes in with a suspected diagnosis of sepsis. So earlier on, I mentioned about IL-6 and how it was also used as a marker of as an indication of this huge inflammatory response that could be indicating that patients are experiencing cytokine storm, especially during the recent COVID-19 pandemic. So here is actually some data to show that in COVID-19 patients, extremely high levels of IL-6 was strongly associated with the presence of septic shock or sepsis in COVID-19 patients. So you can see here that the y-axis looks at the maximum plasma of IL-6, and you can see that there's a huge difference between non-sepsis and septic patients. PCT has been a long-standing biomarker of severe bacterial infections, and you can see that the maximal levels of IL-6 were strongly associated with high levels of PCT as well in COVID patients as compared to patients with low PCT levels. So that is a very strong correlation there. So just to give some overview on our Access IL-6 assay, it assists in the quantitative determination of IL-6 levels to aid in the study of inflammatory disease, and it identifies inflammatory response in at-risk patients. So not only for sepsis or as an indication of cytokine storm in COVID-19 patients, actually IL-6 is also elevated in many inflammatory type conditions, but I won't really go into that today because that would be a little bit out of scope for this talk. But just some specifications on the assay, it is less than 35 minutes time to first result, 28 days open calibration over impact stability. Sample type can be serum or plasma, and sample size is about 110 microliters. So this offers a solution for you on the immunoassay platform to identify severe inflammatory response earlier. And also during the pandemic, we saw that it helped physicians to more effectively assess and triage COVID-19 patients earlier. As we exit out of the pandemic, it can still be an indication of an inflammatory response. I think in this case, its use is still fairly novel. I would say it's not really established in practice yet, but it can be an early biomarker for patients who may be turning septic. So as we talk about IL-6, I also showed the strong correlation between IL-6 and PCT in those patients. I want to highlight a little bit about procalcitonin as well. So what is procalcitonin? It is a peptide precursor of the hormone calcitonin. It's composed of 116 amino acids and is produced by the parafollicular cells of the thyroid and the neuroendocrine cells of the lung and intestines. And in healthy individuals, PCT concentrations are really very low. So how do we use PCT clinically? As you can see, the clinical usage of PCT has been very well developed. Less than 0.5 nanograms per mil, there's a low risk of severe sepsis. Between 0.5 to 2, there's a moderate risk, and above 2, there's high risk of severe sepsis or septic shock. How does PCT actually work? PCT can accurately predict bacterial infections derived by blood culture positivity. So you can see here in this graph that the percentage of positive blood cultures increase with increasing PCT values. And I think I discussed earlier that the problem with blood cultures is that it has a long turnaround time. It takes 24 to 48 hours to successfully cultivate out the blood cultures. But you can see that with increasing concentrations of PCT from 0.1 all the way to 1, there is an increasing correlation with the increased percentage of positive blood cultures. So it can accurately predict bacterial infections. So how is PCT used in sepsis clinically? So in all patients whom sepsis is suspected, PCT can be tested. And in some countries where PCT usage is very, very mature, I would say that PCT is very, very widely ordered, even in the emergency department when patients first come in with certain suspicions of sepsis. So specimens which can be collected at the time of hospital admission, like I mentioned earlier, in the emergency department, or actually any time in the hospital when they suspect sepsis, and it can be repeated within 6 to 24 hours to aid in differential diagnosis of sepsis. And you can repeat it every 24 hours in patients who are at risk of developing sepsis and organ dysfunction. So you can see here that PCT does have have correlation with increasing SOFA score, and I mentioned the SOFA score as a sepsis-related organ failure assessment. So a higher SOFA score would indicate that the patient is having a more severe presentation or more severe condition with relation to organ failure. And in contrast, you can see that CRP, which is a very common inflammatory marker that's also used, does not have this clear correlation that PCT does with CRP. But again, CRP is very commonly ordered because it's a common inflammatory marker and it's also very cost effective. But I think this graph really highlights that CRP is unable to clearly make that correlation with PCT, with sepsis as unlike PCT, which you can see that there is an increasing correlation, it's a clear correlation with increasing SOFA scores. So overall, we have seen that PCT can improve the diagnostic accuracy for early sepsis detection. You can see that in a clinical model of predicting early sepsis detection, the area under the curve without PCT is 0.74, area under the curve with PCT is 0.94. So for our access PCT assay, we have done a concordance study, and we have shown that whether it's on the Access2 or the more high volume DXI 800 platform, overall there is good correlation with VIDAS, the Architect, and the Elexis BRAMS PCT. And at the clinical decision cutoff points of 0.5 and 2, which I mentioned earlier, right, where the patient is visible 2, there is a high risk that the patient is developing severe sepsis. There is also a very good correlation, concordance, whether PCT is being assessed on the Access2 platform or the higher volume DXI platform. So overall, the Access PCT assay shows strong correlation and method concordance to BRAMS PCT methods. So PCT levels, like I mentioned earlier, correlates to the severity of bacterial infections and the probability of positive blood culture. And the physicians need a fast and efficient way to identify patients at increased risk for sepsis. And so these are some specifications of our PCT assay. The time to first result is 20 minutes. Calibration open pack stability is 42 days. So overall, when you consolidate PCT testing to your routine workflow access immunoassay systems, laboratories can experience greater efficiency. So now I want to come in and talk about the last novel biomarker that we have available to manage to detect sepsis earlier, and this is the monocyte distribution width, which is a marker that measures the severity of infection. So monocyte distribution width measures the increased morphological variability of monocytes, and this is because monocytes are one of the first immune cells that are the first line of defense in response to bacterial, viral, or fungal infections. So this can help to assist clinically with patient assessment because a higher MDW value can equate to a higher relative risk of severe infection. You can see here that the MDW values are increasing in the control group of patients who have severe inflammatory response, patients who are diagnosed with infection, and patients who are sepsis. So you can see that there's an increase in monocyte distribution width, which is indicative of activated monocytes, which are responding to a severe infection. So here we say that MDW can be a severity of infection marker. This is actually a case study from Dr. Nima Sarani, who is one of our users of monocyte distribution width on our hematology instruments. And this is reported out as part of any CBC with differential. So this was a case, and it's actually only presented for educational purpose and may not reflect a typical triage process. So patient comes in the ED at 9:30 with certain symptoms and the vital signs are assessed. Typically, a CBC differential is always ordered, right? As the first, one of the first tests they're ordered. They saw a decrease in hemoglobin, but they don't know if this is a worsening of anemia. And they did see elevated white blood cell count. MBW was elevated at 27.3. So our cutoff for MBW for early detection of sepsis is 20. So in this case, this patient came in and had already had an elevated MBW. When he examined the patient, there was evidence of hot site infection and antibiotics were given. At which point the lactate was then ordered and it was 3.2. So this is time zero. Time zero, again, like I mentioned earlier, is defined as the time of presentation of the conditions of sepsis. So from the time at which patient comes in at 9:30 to time zero, it was 2 hours. But if you think about it, if MBW was available to this patient at that point in time, the time zero might have been a lot earlier. You might have been able to halve that time because then the physician may have been alerted to a suspicion of sepsis and ordered that lactate earlier. So this is actually a quote from Dr. Sarani that says, by including MBW in the thought process, they could have potentially uncovered an underlying sepsis that could otherwise have been missed because other causes can explain patient symptoms. So what is the benefit of monocyte distribution width as a novel biomarker? I think I mentioned earlier that a lot of biomarkers, novel biomarkers, are not available on high throughput automated platform. The beauty of monocyte distribution width is that there's no workflow changes, right? It's available automatically as part of a CBC differential test on our hematology analyzers. It uses the same filter principle. Because it's not an additional test that does not need to be ordered, there is no incremental cost to the patient. It enhances white blood cell count interpretation in that it helps to identify patients at risk. So you can see here that right, the red line is the white blood cell count. The area under the curve for predicting sepsis is 0.75. And when you add MBW to the white blood cell count, its area under the curve actually increases from 0.75 to 0.85. So overall, it enhances WBC interpretation to help identify patients who may be at risk of sepsis. So what does it mean, right? What can MBW do? Overall, it can help to reduce diagnostic uncertainty because this is still a major challenge for patients presenting to emergency departments with a low number of signs and symptoms. And, over 30% of septic shock patients present with very big symptoms and may be missed. In fact, in the emergency department, it's actually the most frequently misdiagnosed condition. And this is due to a very high workload in these emergency departments, especially as we're just coming out of the COVID pandemic. And cognitive factors and process efficiencies are also main contributing factors to diagnostic errors. And initial disposition home of ED patients with potential sepsis can result in 2 times mortality and 4 times healthcare costs. So can you imagine if there was an MBW available to that particular hospital, we could reduce that time, the time to time zero at which a sepsis patient is diagnosed. So overall, what we have seen in our research studies and in real life in clinical practice is that when MBW is available early in patient assessment, it can help to determine patient acuity and risk of sepsis. And if you're interested, we can also share the many clinical data that has been published over the last few years. Overall, MBW values below the cutoff actually decreases the probability of severe infection and risk of sepsis. So it can actually work both ways. And above the cutoff increases the probability. So I've talked about how a high MBW can reduce the time to time zero. But at the same time, on the flip side, the patient comes in with certain signs of infection, but MBW is very low. This can indicate a reduced probability of severe infection, and it can help the physician in making the decision whether or not to administer antibiotics. And this also helps to manage the antibiotic, the emerging or the rise in the incidence of antimicrobial resistance that we see so widely in the region. So just to summarize part of my talk, MBW is really the only proprietary regulatory cleared hematological biomarker. So there are many hematological biomarkers that have been implicated in sepsis or in severe infection, but MBW or monocyte distribution width is the only one that has been cleared by FDA and the European regulatory agencies, and is exclusive to Beckman-Coulter analyzers and can help to identify severity of infection and risk of sepsis. Overall, it helps to reduce diagnostic uncertainty and helps clinicians in escalating or de-escalating care. And this depends on whether the MBW value is above or below the cutoff. And more importantly, it's available early on in patient assessment as part of the CBCU differential, no impact to workflow, no additional tests has to be ordered, and no added cost to patient. So overall, I think we would like to present that we do have this complete portfolio to help in the early detection and management of sepsis. So in terms of immunoassay, we have PCT available for treatment decisions, and we also have IL-6 as well, alongside the more common biomarkers like CRP or lactate. And again, it's about consolidating the workflow to automate sample processing and reduce the turnaround time for that sepsis panel report out. Okay, we also have a microbiology panel that can help to drive antibiotic therapy and antimicrobial stewardship decisions. We have rapid bacterial ID antibiotic susceptibility testing for a vast majority of sepsis causing microorganisms. And this helps to reduce the reporting risk with a broad range of first-time reporting. It helps to reduce costs with minimized reflex or offline testing, and there's actionable data to inform patient therapy and management decisions. So overall, we've looked at the immunoassays, the clinical chemistry, hematology, where I talked about MDW, microbiology and urinalysis platforms. And overall, with this complete portfolio, it does help, and it's all tied together with our clinical informatics as well, right? Helps the physician to know sooner and act faster with this interdisciplinary portfolio of both common and novel biomarkers for all stages of managing sepsis. There's also flexibility and breadth to support protocolization of sepsis management, depending on how the institution wants to protocolize sepsis. And with the availability of clinical informatics, it can help to manage that data to automate and expedite delivery of time-critical results. So with that, I've come to the end of my presentation. This is actually my last slide. I thank you for your attention, and I'm happy to take any questions. And in fact, I see a question here. Is PCT a useful sepsis biomarker? And can I just quickly answer this question?
Sure, Dr. Proceed.
So yes, we have seen some data that PCT is a useful sepsis biomarker in pediatric groups. But again, the neonate cutoffs are actually very challenging, as you know. I think there is some data out there, but at least for our access PCT, we don't have that clear indication. And I think currently the evidence is clear that it's a useful biomarker even in the pediatric cohort, but cutoff levels, I would say that for different age groups are still not clearly established across the different assays at this point in time. It's not as clear as for the adult cutoffs of 0.5 and 2.
Okay, I think there's no question. Oh, there's another one in Q&A. Do we need a group of tests in the diagnosis of sepsis? Will it be sufficient just PCT?
Can you repeat that question again?
Yeah, sure. Do we need a group of tests in the diagnosis of sepsis? Will it be sufficient just PCT?
Oh yes, we definitely need a group of tests because sepsis can be caused by a variety of microbes and not just bacteria, right? Generally, PCT is elevated in response to the endotoxins and exotoxins that are being released as a result of bacterial infection. So for example, it may not be as elevated in other types of infections caused by other microbes. So we do need other tests, like for example, IL-6, to kind of determine whether there is this huge inflammatory response going on in a patient with an infection, and so that this patient can be managed, or for example, even just be admitted into the hospital for further observation instead of sending that patient home and then waiting for that condition to deteriorate.
Okay, there's no question from the participant yet. Maybe I have a question for you, Doctor. Just want to ask you, how do we use these novel biomarkers for the post-mortem diagnosis of sepsis?
Post-mortem, wow. That's a very interesting question.
Any studies done on it?
Vani, I think that in post-mortem cases, I think you would probably have to do more tissue dissection and histopathology types of analysis. And probably you could see, if, for example, if you catch them at a point where there's that huge inflammatory response going on, you could probably see histopathology staining of IL-6 or other types of inflammatory markers. That's something that I can just think of post-mortem.
Okay.
Yeah, but definitely, I think you would see inflammatory markers being elevated. And then, of course, if there's evidence of organ dysfunction, they could conclude that the cause of death was sepsis. But that's just my interpretation of, that's just my interpretation of an answer to your question.
Okay, sure, doctor. I think there's no question yet. Since we have another 5 minutes, maybe I'll ask you another question.
Okay, sure.
Yeah. Do you consider relevant use of procalcitonin or MDW in septic complication after trauma?
It's possible, yes. I would say that the use of MDW is more effective. Okay, so definitely MDW could be elevated in trauma patients as well as with PCT. Again, I think it depends on the condition, right? So, but I think the utility of MDW is really the greatest when patients are coming in with mild symptoms of infection. So if MDW is high, the physician may think about admitting this patient in for further observation. Usually trauma patients come in, they already be admitted to the ICU or high dependency ward, and they will be observed very closely. And of course, all these biomarkers will be ordered as well. But I think where the greatest utility may lie, for example, for MDW, is for those patients who seem okay, maybe they have a fever or slightly increased respiratory rate, and the physician is thinking, okay, there are no beds in the hospital, ED is very crowded, maybe I send this patient home first and ask him to come back again if he feels worse. And those are the cases that tend to get missed, especially with a busy emergency department, or in situations where sepsis is not protocolized yet. So having MDW, very high MDW, can help to act as an alert for sepsis in these patients. So to answer your question, Vani, yes, these biomarkers can also be used in trauma patients, but I would say that because they're already being admitted and being monitored very closely, the utility, for example, of MDW is still the greatest in patients who are coming in and they seem okay otherwise, other than just some very mild symptoms.
Okay, so probably one last question, doctor, from the participant. I often see clinicians order for ferritin and LDH for COVID patient. How does it work in managing sepsis?
So, again, COVID patients also have this interesting situation where an initial viral infection can deteriorate very, very quickly, resulting in massive shutdown of the organs. And I think this is because the coronavirus can actually enter, as you may know, right, enter via the ACE2 receptors on many, many organs other than just the lungs. And so I think with that order of ferritin, again, ferritin is released when there is this huge inflammatory response, and there's organ dysfunction starting to happen. And again, for lactate, right, LDH, it's also a marker of organ dysfunction. So I would say that I think the physicians are ordering it as an indication that these COVID patients are not just having regular respiratory symptoms, but they are progressing into a more critical state. So it's an indication of how do I manage these patients? Do I put them on more aggressive treatments? Do I move them up to the ICU, or do I even admit them, right? So it's trying to manage and I guess triage these patients as they're coming in. So I hope that sort of answers the question a little bit.
Okay, we have another 2 more minutes. Just a 1 minute answer, doctor. Thank you for the comprehensive lecture on sepsis. Okay, I would like to ask, is there any cut-off PCT level to differentiate between viral and bacterial infection? Then second one is it appropriate to order both PCT and CRP simultaneously? And the third question is there any recommended intervals to order PCT to make it cost effective?
Okay, so first question, PCT does not discriminate. So PCT, elevated PCT indicates that the patient is having a bacterial infection, not viral, and therefore you can administer antibiotics. Therefore, it's often used as part of antibiotic stewardship management decisions. Second question, can you order PCT and CRP together? Yes, you can. What was the third question again, Vani?
The last one will be, is there any recommended intervals to order PCT to make it cost effective?
Okay, so the recommendation is you can order it every 24 hours if you want. I think on the first day, it's recommended 6 to 24 hours. You can repeat that, but subsequently you can order it every 24 hours as well.
Okay, Doctor, I think there are a few more questions coming in, but due to time constraint, probably you can answer them via the chat box.
Okay, sure,
Is it
sure.
okay? Yeah.
Sure.
Okay, so with that, is there anything else you want to say before the wrap up?
Thank you for the very rigorous discussion. I actually really enjoyed it, and it made me think a little bit more about this topic as well. So I appreciate all the questions and discussions. Thank you very much.
Okay, with that, we'd like to thank you, Dr. Pauziwe, for taking your time to join with us. Hope to see you physically in our next future conference.
I hope so too. Thank you very much.
Thank you. Yeah, thank you.
Bye.
Bye, see you. Yeah, dear participants, you may leave this session and go back to the lobby and join me for the following lecture.